this is a debate. So obviously, usually in medicine, nothing is ever black or white. So it's a sort of gray intermediate. So I'm advocating the fact that maybe we can do without a transplant in Philadelphia positive ALL, although in my presentation, I will not say this is for all patients, but for a notable proportion of patients, this may well be the case. And I'll strongly support this position by saying, first of all, that we know that the incidence of the Philadelphia positive ALL increases with age. And I show a slide where it's indicated that, in fact, patients who are older have a higher likelihood of carrying this, the BCR abelson. And indeed, it's at least 1 out of 2 B-lineage LL cases in patients over the age of 50, 55. So in the less young patients, it's a very high proportion of patients carrying this abnormality. So that's one point that we should keep in mind. The second point is I will advocate the fact that MRD negativity is a key point in the management of ALL in general and in Philadelphia positive ALL, and that we know that if patients become MRD negative, and this should be done by molecular quantitative PCR monitoring, and repeatedly negative, these patients do significantly better than patients with still a signal of residual disease. So that's the background, age and MRD. So then in my presentation, I will show the updated result from the D-ALBA study that we carried out and published in the New England Journal in October of 2020, and for which, in fact, we also wrote a review in New England that came out only a few months ago, specifically on Philadelphia positive ALL. Now, in this study, this was for frontline patients of all ages, from 18 up with no upper age limit, so all the elderly were included. And then it was based on induction with the Dasatinib followed by Blinatumomab. So it was induction consolidation without systemic chemo. The bottom line is that a high proportion of patients showed a molecular response that went up to 60% at the primary endpoint and even to 70-80% at the longer follow-up. We present data with an update at roughly 4 years, and the curves are very, very good, keeping so. And what is more important in the context we're talking about, that patients who remain in molecular response over time have so far, with a follow-up of 47 months or almost 4 years, have so far had no events. And many of the patients have not been transplanted. A few have, because the protocol left it open after consultation to the treating physicians. The other point is that in the study we showed that Dasatinib could induce a host immune modulation in patients. That means that we're activating the host immune system, and this was seen not only in young patients but also in older patients, patients greater than 55. So this may contribute to control the disease. The other point, that the transplant was, as I mentioned, was left open to the centers. And in the ALBA study I'm talking about, 50% of patients were not transplanted. And so far, there's no evidence that transplant does increase the rates of survival. So the message is, I won't go into that, but the message is that you can do without transplant, apparently. The host immune system is activated, and with this combined TKI plus immunotherapy, very high rates of molecular sustained responses. Now, this does not formally prove that you can avoid the transplant, but this will be formally proven, at least we hope, with our current protocol, which is open and has enrolled now over 50 patients. And in fact, in the study, patients who are MRD negative and don't have other unfavorable genetic features will not be transplanted, even if they have a sibling donor. So that will definitely prove what we're saying, that in a proportion of patients we can avoid transplant. And in passing, I may say that the French group, the MD also says that you can avoid transplant if you obtain a molecular response. The key point is the deepness of the molecular response to treatment. So if the question is, and I discussed it recently in a meeting in Nice, if an allogeneic is mandatory for all eligible patients, I said then my answer is no for a number of reasons I won't repeat now. But I said for all, clear if you have MRD, residual MRD, you have other genetic and favorable marker, then transplant is probably to be done. But this means that many patients probably avoid this. Now the question is, I will conclude my presentation saying, however, that to do all this, you need many factors to be working. You need a very close relationship between the clinic and the laboratories. This has to be done. You have to make diagnostic workup, you have to define sub-entities, you have to do biologically based prognostication, you have to do MRD in the best possible way, and that in our view is molecular. So all this has to be put together. And is that doable around the world? Well, the point is exactly that. I think that this is a major limitation, because very often this is not exactly doable because you lack all this. So I think if you're in a fortunate part of the world where things like this can be done, then in my view, many patients can be spared a transplant. And I think this will be important, particularly for the elderly, less young. I mean, in acute leukemia, 55 is already not young. So I think that is the bottom line. We can't say that all patients will be spared, but I think a large proportion will. And that is our hope, and we hope to increase that percentage in the future.